And good morning, good afternoon, good evening. We've got multiple time zones going on here. Thank you for taking the time to join us for PQMD's Pillar Talk Context Matters, Response Perspectives from the Turkey and Syria Earthquakes, a part of a larger series of webinars which the PQMD community offers to address major trends, leading thinking, best practices, provocative issues in global health. I am EJ Ashbourne, or Elizabeth Ashbourne. I'm PQMD's Executive Director, and I want to welcome you on behalf of our entire team. For those of you who are not familiar with PQMD, we are a global alliance of international NGOs and leading healthcare companies committed to advancing the role of productive product donations worldwide. Founded in 1999, our work is guided by 5 pillars: humanitarian assistance, health system strengthening, disaster response preparedness, guidelines, and knowledge management. Today, the work of our members is central to the global response to universal healthcare by promoting sustainable access to quality healthcare in underserved communities and displaced populations in crisis. And many of our members have been responding to the protracted crisis that has been unfolding in Syria for the past decade. And we're first to respond when the devastating earthquake hit Turkey in February. So very quickly, I want to review just a couple of housekeeping rules. Go ahead and warm up your fingers. Please type your name in the chat box and let us know the organization that you are with as well. While we request all participants to remain muted, we do invite you to use the chat box for questions and comments. This session is being recorded and will be posted on the PQMD Community of Practice this week. And I will share the link of PQMD's online community of practice in the chat box. So please be sure to join the timely and informative discussions with our members there as well, if you haven't already done so. So now I have the pleasure of introducing and turning it over to Courtney Suna, who will be moderating the session. Courtney is the Director of Global Community Investment and YHP at AstraZeneca. Courtney leads corporate partnerships and community investment initiatives spanning 40+ countries, overseeing AstraZeneca's global giving budget and global corporate foundation, including medical donations, product donations, humanitarian response, and employee giving. Courtney's background is in leading and implementing effective healthcare initiatives towards the Sustainable Development Goals. During World Refugee Awareness Month, we are thrilled to have Courtney lead this discussion on the complexity of responding to an emergency in fragile, conflict-affected, and vulnerable settings, and how we as the global health community can more effectively respond and support populations in crisis. Courtney, over to you.
Thanks, EJ. Hi, everyone. Good afternoon, evening, morning, wherever you are from. It's so exciting to be speaking at this event today. I've had the great pleasure of meeting many of you in person at the PQMD meeting in April. So seeing your name on screen today is really nice. So good to see some of you again. It's really an honor to speak at this inspiring gathering of people focused on the critical subject of humanitarian response in the face of simultaneous emergencies and protracted crises. Today, I want to shed a light on the pressing issue that has plagued many regions of the world: how humanitarian organizations can effectively respond to emergencies when they strike locations that are already grappling with longstanding crises. In recent times, we have witnessed devastating earthquakes in 2 regions that have been at the forefront of global attention: Turkey and Syria. These earthquakes, occurring amidst ongoing conflicts and humanitarian challenges, have not only tested the resilience of the affected communities, but have also posed immense challenges for the humanitarian response teams. When such dual crises emerge, it is imperative that we recognize the intricate nature of these emergencies. The earthquakes have exposed the vulnerabilities of societies that were already grappling with protracted crises, be it armed conflicts, displacement, or the erosion of essential infrastructure. The impact of such emergencies is then multiplied, rendering the situation far more complex than any single disaster. But in the midst of the darkness of these crises, there have been beacons of hope. Humanitarian organizations working tirelessly on the ground have exemplified resilience, resourcefulness, and the ability to adapt to the evolving needs of affected communities. They have demonstrated that even in the most challenging circumstances, there is always a path forward towards providing much needed assistance and support. In order to enhance the effectiveness of our response efforts, it is crucial that we adopt a multifaceted approach. Firstly, we must strengthen coordination among humanitarian organizations, local authorities, and international partners, because collaborative action based on shared objectives and mutual support is vital for a comprehensive and integrated response that both addresses the immediate needs and considers the long-term recovery of the affected communities. Secondly, we should prioritize the building of local capacities and resilience. Empowering local communities to actively participate in their own recovery is paramount, because providing training, resources, and opportunities for self-sufficiency, we can not only respond effectively to immediate crises, but also lay the foundation for long-term stability and development. And lastly, we need to leverage technology and innovation to enhance our response capabilities. The rapid advancement of technology provides us with invaluable tools to improve early warning systems, enhance communication networks, and optimize resource allocation. So embracing these technological advancements will enable us to respond swiftly, efficiently, and with greater precision in the face of simultaneous emergencies. Before we get started with the discussion, let us just remember the resilience and strength exhibited by the people of Turkey and Syria, who, despite the compounded challenges, have shown us the indomitable human spirit, and it is our collective responsibility to provide them with the support that they need and deserve. Joining me today is Dr. Mohammed Al-Jassem, the health coordinator for Syria for the International Rescue Committee, Adam Jokovu, Turkey country director at Project Hope, and Michelle Thompson, associate director of emergency response at AmeriCares. By coming together, sharing knowledge and resources, we can build a proactive and integrated approach that saves lives, restores hope, and ultimately paves the way for a brighter, more resilient future where no community is left behind in times of crisis. So we're going to start off today with a bit of a round robin. So a question to each of our panelists. Before the earthquakes hit in February, can you tell us about your work in the region and how the earthquake changed your course? We'll start first with Michelle, followed by Dr. Mohammed, and then Adam.
Thanks so much. It's really a privilege to be here speaking to this group about this important topic. AmeriCares has provided assistance to Syria and to Syrian refugees in neighboring countries for more than a decade, and I've been privileged to lead that effort for the past 7 years. We've been providing regular shipments of medicines and medical supplies to support more than 50 health centers in the northwest of Syria, financial support to ensure health access through projects like mobile health services and new facilities to support people experiencing displacement, and also technical assistance in mental health and psychosocial support. Our goal in an emergency response at AmeriCares is primarily to restore access to health services and to increase the resilience of a community so they can better withstand future emergencies. And we know that in a protracted emergency like the Syria conflict, new emergencies layer on top of that root emergency. And the earthquakes were not the first of these layered emergencies, but they were certainly the largest. Responding organizations have had to wrestle with a cholera outbreak, a pandemic, severe weather events impacting shelters, and countless spikes in violent conflict. All these emergencies take a toll on those experiencing them, and that includes local responders. They also take up resources for the longer-term health system strengthening goals that we all share. We're all aware that the needs in Syria were severely exacerbated by the earthquakes, and for a very brief moment, media coverage and funding increased and helped us all to do a little bit more of that important work that ensures health access. And this is really important because, as you know, the International Syria Response Plan is severely underfunded. So AmeriCares quickly layered on a response to the earthquakes in Syria and Turkey. It's actually because of those longstanding relationships with our local partners that an AmeriCares shipment of life-saving medicines, surgical supplies, and wound care products arrived in Northwest Syria only 3 days after the initial earthquake. At that same time, we also mobilized a response team to the affected area in Turkey. And through our assessments, we met and partnered with a number of new organizations there. And our earthquake response consisted of our typical response elements. More than 17 tons of medicines and medical supplies were delivered. $1 million in emergency grants to local partners that covered everything from purchasing fuel for keeping ambulances running to building a clinic for displaced earthquake survivors in Syria, and a rehabilitation center for children in Turkey that also provides psychological counseling for patients. And now we also continue to provide mental health and psychosocial services to impacted frontline workers.
So, hi everyone. I am Mohammed Jassim. I am the coordinator for the International Rescue Committee, responsible for the management of the health projects implemented by IRC for Northwest of Syria. So the IRC, IRC is an active health partner since 2013, responding to the emerging health needs northwest of Syria. Actually, IRC is working directly and through partners to support plenty of health facilities, different level of care, including primary health care, secondary health care, and specialized health services, including the MHBSS services, through direct implementation and partners. Mainly, we are working with partners as the ultimate objective for IRC is to enhance the local systems and to make more efficient the governance of the system. Before the earthquake, IRC used it to support around 22 health facilities in Northwest. So majority of these health facilities are primary health care centers, and also we are supporting two hospitals or two trauma hospitals. One of them is the biggest hospital in Northwest, is Idlib Surgical Hospital, and the other one is the Adarib Hospital. And also IRC used it to support the MHBSS units, inpatient and outpatient unit, as these services kind of unique services and cannot be afforded by all the health actors. Also, part of the response or part of IRC business in Northwest is also to provide the medical supply chain and pharmaceuticals to all the health facilities, either it's supported by IRC also or by other health actors. Also, IRC is member of the health cluster and member of the technical working group under the health cluster umbrella that addresses the technical characters, the technical management of all the health activities in Northwest. Actually, IRC is the earthquake has impacted at the two sides of the borders. As everyone knows that the response for Northwest of Syria specifically is through cross-border operations, which means that most of the health actors are based in Turkey and use these humanitarian corridors through the Turkish-Syrian borders to supply the Northwest to the different supplies, including the pharma supplies. So our teams who usually based both sides of the borders, mainly inside Syria, also in Turkey, have been impacted personally. Two of IRC members have unfortunately passed away with their entire families. So the first damage or first consequence to the IRC is about the human resources loss, especially in such environment where there is lack of health, there's lack of the human resources, especially for the health workers. As the biggest response for IRC is the procurement of medical supplies, including the non-communicable diseases kits, the surgical kits, including the trauma kits and the intensive care units kits. So the first important point that have been highlighted by most of the health actors, including WHO, at the first early hours of the earthquake is about the shortage of the medical supplies recorded at all the health facilities. And as part of the response, actually IRC started to with the procurement of medical supplies, including those essential supplies that used to be procured by the WHO during the past 7 years. And the total value of the procurement was around 3.5 billion, including this ECD case or LC case and the trauma case. Also to sustain or to maintain the connectivity of the 22 health facilities that IRC used to support it through the existing donors of the existing grants. Since more than 5 or 6 facilities have been suspended partially or completely due to the damages of the unconnectivity of the infrastructures that these facilities used to operate. Also, as part of the response of the earthquake, also to support the ambulatory system by providing more ambulances care that sustain or enhance the referral mechanism already existing between the health facilities. Unfortunately, the Syrian context, more than 10 years of crisis over the last year, due to this large displacement, more than 4.1 million of Syrian populations are residing in Northwest. 60% of them are considered as IDPs. The lack of infrastructure, the lack of the human resources dedicated, particularly as gynecologists, midwives, or even health workers, lack of MHBSS professionals, lack of a proper infrastructure, and also the conflict itself still continues without the end or without a final solution. In light with the Security Council resolution, which imposes, especially in the last 2 years, a kind of restrictions for the health actors to respond and to make a long-term planning and to enhance the governance of the system, of the health system. So based on these basic resources and based on the restrictions imposed, unfortunately, internal factors and external factors, this is the health system that actually it's weak health system, it's fragile health system, and unfortunately, during the past 10 years, with COVID outbreak, with cholera outbreak that recently announced in the northwest of Syria, with the lack of the resources, with the reduction of the fund, and also the earthquake that occurred the 6th of February 2023. All of these factors, unfortunately, forced everyone to admit and to acknowledge that this health system that's already existing in Northwest is unable to meet the basic standards and to meet any emergency response. That's it.
Thank you, Mohammed, and over to you, Adam.
Thank you, Courtney, and thank you, Dr. Al-Jassem. Pleasure to be here, everyone. My name is Adam Jakobu, and I'm the Country Director and Response Lead based out of Turkey for Project Hope. Project Hope is a global health and humanitarian organization. And prior to the earthquake, we had no presence in Turkey or Syria. However, we were able to mobilize a rapid response team, emergency response team on the 7th of February, which is the next day. And over those coming days, that grew into a fully functioning country mission. That initial team comprised of logistics staff, finance staff, communication staff, team lead, and importantly, health expertise, technical and mental health and psychosocial support. Different to us is that we had no before and after, so everything was new. So we were starting from a blank canvas, and that presents many challenges. So you were trying to start up the operational side of the mission, whilst concurrently do assessments and ensure that you're delivering humanitarian assistance, both immediate, but also thinking in the coming weeks and months ahead. So there's a lot of moving parts to get going, and so there's a big emphasis that we had on logistics. And not being in country, one of the, I guess, disadvantages was not being tapped into the various pre-existing coordination mechanisms. So a lot of effort went to make sure that we were doing that, and that was with the humanitarian community through the United Nations Coordination of Humanitarian Affairs, OCHA, other UN agencies, other NGOs, civil society organizations, but very importantly for Project Hope, given our circumstances, that was to directly speak to the different health directorates, which fall under the auspices of the Ministry of Health in the affected provinces. So that's where a lot of our initial information came from, that informed our initial decision-making processes. We also undertook needs assessments. The coordination formed part of that, but also visits to health facilities and to affected populations in informal settlement. The culmination of this kind of groundwork was to support a partner organization with initial search and rescue activities in the initial days following the earthquake. Support to healthcare staff with blankets, sleeping bags. Well, while it's not health, it's per se, these were people that were working in an extreme environment in terms of the circumstances, but also the weather. And so we wanted to make sure that they had the right shelter to enable them to do their jobs and affect those that had been injured and needed medical assistance. We also provided shelters for those people, containers. So importantly, we were able to receive, thanks to a number of kind donors, a lot of good gifts in kind, medical donations, medical supplies, equipment, medicines themselves, emergency health kits that designed to serve around 10,000 people for around 3 months. We provided incubators, assisted devices, wheelchairs, crutches. Very importantly, hygiene kits was very much requested, particularly within the informal settlements, where the hygiene standards were subpar, particularly in the early stages of the response. And over time, I guess we evolved into continuing this provision of humanitarian assistance, working directly with the authorities, but we really wanted to start working with local partners and tap into that knowledge, that pre-existing knowledge of the communities that we're serving, of the context itself. And so we've grown by developing healthcare programs and mental health care programs with a number of partners throughout Turkey, as part of our kind of localization policy and our commitment to the grand bargain commitments. So in Syria, again, as I said, that we were new in country, it's difficult terrain for us to go in directly, but again, we identified a local partner that was able to establish 2 vital mobile medical units, staffed by doctors, nurses, and the requisite medical supplies. And they have been functioning since the first couple of weeks after the emergency response. These are key to get access to displaced populations that otherwise would not be able to access health facilities.
And that is the truth. And nobody died in the Holocaust either. Yeah. That's the truth.
Oh, Adam, you're muted now. There must have been
I think someone muted me, sorry. So these mobile medical units are in the process of transitioning to supporting static primary healthcare centres with primary healthcare. I think just one comment to make would be that it's very important, particularly in Turkey, that we consider all the affected populations. I'm going to give you a number now, but it's just my feeling. I would say that the authorities in Turkey are probably hitting anywhere between 70 and 80% of the humanitarian needs in country. The remaining 20 and 30% of those needs is extensive. The humanitarian community is not able to fill that 20 or 30% of remaining needs. But what's important is that those needs are, I would say, the more vulnerable populations. Those, for example, Syrian refugee populations, persons with disabilities, Roma populations, etc., etc. And so the real added value of international and local humanitarian organizations across all the sectors is really to make sure that those that have kind of, I don't want to say it, but perhaps slip between the cracks, they are not forgotten. And again, it's important that with our approaches that we consider both the affected Turkish population that have gone through significant change very quickly, and then the Syrian population that is experiencing a crisis upon a crisis upon a crisis. So we're very conscious of the social cohesion that's necessary as well. So
Absolutely.
I probably missed out a number of important health-related things that we've done, but that's it in a nutshell.
Great, thank you all for your comments. And I think that's a really important distinction to make, Adam. And for the organizations that are really responding while at the same time setting up for the first time and trying to work with local partners, you're really trying to build a plane while while flying it, and that's no easy feat. So thank you for all of your incredible work. And turning to you, Mohammed, you spoke a little bit about how the earthquake further impacted already strained health systems, and then the outbreaks of cholera and COVID further exacerbated the situation. Can you speak a little bit about what that impact was, and elaborate a little bit on your remarks on that, please?
Yes, for sure. Actually, the fragile health system, it's because it's fundamental reasons during the past 10 years, because of the displacements for the northwest of Syria before the crisis. It's actually, let's say, traditional areas which were not equipped or infrastructured with developed health system to meet the health needs with more than 4 million populations. This is the first issue. The second issue is related to the population itself. So its camps areas, more than 60% of the population now in Northwest are residing in camps areas, where the infrastructure is already weak due to sanitation access of the lack of the resources. In particular for the health, actually, there's kind of issues related to health, especially about the number of the health facilities, for example. Some health facilities cannot, the services provided inside these facilities cannot meet the health needs of 4 million populations. The second issue is related to the supplies itself. Shortage of supplies recorded at the health facilities at the early hours of the earthquake. Because it's the poor planning because of the earthquake, because everyone was for procuring supplies and store it just to sustain the connectivity of the health facilities during the period before the earthquake. The third issue is related to the lack of the human resources, specifically for the health workers. As all of us know, that a biggest portion of the health workforce migrated out of Syria, especially the doctors, the gynecologists, the pediatricians, the nurses, and due to this long period of a crisis, there was no proper education system to qualify more health workers to be dedicated to the health system. The fourth issue is related to the cross-border operations itself. The modality of the response for the Northwest is actually limited, restricted by this Security Council resolution issued in 2014, number 2642, which limited everyone, including the UN agencies and the international organizations, to intervene, to have their personal staff inside Syria to cross on a regular basis, also to supply the health facilities or to supply the health system. Also, the biggest issue is related to the governance of the health system. As all of us know, that this area is out of the control of the government. So there is no government or there's no Ministry of Health. The planning of the health system is controlled by the UN agencies under the umbrella of the health cluster of WHO. There is no centralization of the health system, so you can build a long-term planning. All these factors actually, and unfortunately, because of the earthquake, because of the 12,000 deaths recorded at the earthquake, hundreds of injuries. Just one example, in Syria, Northwest, the rate for the disabilities or the people who have injuries or disabilities for functionalities is 25%, and the global figure is 15%. And it refers that 25% of the population have difficulties, have disabilities to access to work, to make a normal life. This is a huge rate that refers to many issues related to accessibility, to affordability of many health services. In particular, for example, the physiotherapy services are totally absent inside Syria due to the reduction of funds. Many of the international organizations, many of the locals, due to the reduction of the fund, forced to prioritize the level of care, forced to prioritize which health facilities should be sustained. That's why many MHBSS service providers had to close their MHB services. Many of health providers forced to close physiotherapy services, for an example, which shows the fragile system and shows the importance to pay more attention to this area.
Absolutely. Wow, thank you. There's so many underlying factors that really contribute to making this such a complex emergency to respond to. And Adam, I know that you touched on some of these, but I wanted to ask you, did the fact that the earthquake was and is an emergency within an emergency, from your perspective and from Project Hope's response, how did that add complexity in terms of meeting the healthcare needs and kind of building on Mohammed's answer?
Sure. I mean, for sure, it does add complexity. And what it does more than anything is it exacerbates an already difficult situation. But I will be honest by saying that it's not exactly something new. You know, when you have an emergency situation around the world, more often than not, it's in a location where there's pre-existing issues that generate vulnerable populations where there is continued programming. So, you know, it's not a new scenario. It's quite a big one with a sheer number of refugees in Turkey, and then the totally immense scale of destruction that is, you know, almost hard to really comprehend. So I think that really the complexity is the deepening of existing vulnerabilities, and that's it really. How has that really changed what we've done? I would say we're conscious of this, and we're conscious of perhaps the mental health aspects of being in a protracted crisis already, having a difficult life, and then to be in a you know, an acute emergency and potentially loss of loved ones or property or whatever. We're very conscious of this, and again, that's why that, you know, at Project Hope, after the initial phase of more life-saving assistance that we did, we've factored into the kind of medium term the mental health and psychosocial support programming through our partners. So yeah.
All right, I was on mute. But thank you, Adam. It's such an important point. And I know, Michelle, you also touched on the mental health and psychosocial support that AmeriCares provides as well, because essentially you're working in a very fragile, conflict affected and vulnerable setting where you have a population of people that is already traumatized, and then in emergency, you know, the earthquake hits and they're becoming re-traumatized and are affected in so many ways. So from your perspective, what types of support has AmeriCares been able to provide, and how does that help contribute to strengthening health systems?
Yeah, that's a really important issue, and AmeriCares is prioritizing the integration of mental health to strengthen the health system particularly, and we're hoping to do that in two major ways. First, through increasing resilience of the current health workforce and frontline responders, and second, by expanding the pool of people that can provide basic level psychological interventions. And we have to think about, you know, the human impact of an emergency within an emergency. I know others have spoken about this as well, but what would it be like to be forcibly displaced 6 times across 12 years? We know that many earthquake survivors have experienced trauma from the war and are now displaced again. And healthcare workers are not exempt from this. In fact, they're doubly impacted because while experiencing the emergency themselves, they're also taking care of patients and exposed to potential secondary traumas and to burnout. So if we want to strengthen the health system, we really have to ensure the health of these frontline workers. And so a key priority of AmeriCares is to support their well-being. And one of the ways we're doing this is to provide structured support sessions for these staff on topics like grief and loss and vicarious trauma. And in many places around the world, we know that there are not enough mental health specialists to meet the needs of the local population. And in Syria, that multi-layer emergency further exacerbates the mental health needs, making that lack of specialists even more of a challenge. So there's a growing movement in our sector and growing evidence that we can begin to meet those needs by expanding the number of people who are trained in the low intensity psychological interventions. Research shows that it's safe and it's effective with the proper levels of training and supervision, and it broadens the capacity of the health sector to meet the increasing needs. So to that end, we've been training frontline workers and community health workers in the region in these low intensity interventions and working to strengthen the supervision structures locally. And we're doing all of that, with the broader goals of increasing that resiliency of the health system and increasing overall access to health, which of course includes mental health.
Thanks, Michelle. I feel like the themes of health system strengthening, building resilience are core to what each of us is doing. And I wonder, Mohammed, if you could speak a little bit to how, what are some innovative approaches that IRC may be implementing to help address some of these health needs to the over 4 million people that are residing in these areas?
Yes, actually, the first step that IRC is right now trying to make more sustainable the system is about the advocacy for the continuous funding of the existing programs in Northwest, because shrinking of the fund or reduction of that will impact the fragile health system that we are having right now. The second, let's say, line that we are working right now is multi-sectoral approach, which refers to the more cost efficiency of the interventions, and more also to meet the different needs of the population, since it is not also, it's not, the major needs are not mainly health needs, are different needs due to this economic situation. The third line that all the health actors is making sure is about a prioritization of the health facilities or prioritizations of the health interventions in light of this shrinking fund. Mainly it's related to the specialized services. I mean the surgery, hospitals, or the sexual reproductive health, or even the services related to the MHPSS services, or even the services that are actually not supported by all the health actors, just to reduce the number of the referrals cases that needs to be referred to Turkey. For example, the cancer treatment services are not available inside Syria. All these cases should be referred to Turkey, and there's kind of restrictions to refer these cases to inside Turkey, or also the cases that need, for example, cardiac surgery. Also, these kind of services are not available now in Northwest. So most of these cases needs to be referred to inside Turkey. Such investment in such, let's say, unique services also can be an advantage in the future to at least make it a comprehensive health system that compromise between the basic needs of inadequate resources and also the emerging health needs. The last line that also all the health actors are working on is about the prepositioning of the supplies, the prepositioning of infrastructure. Because as I mentioned, the last input, it's related to the preparedness or the buffer stock that you have inside your warehouses, for example, for the supplies. So there was a huge concerns about the shortage of the medical supplies. Also, it should be considered by everyone to have a buffer stock in case such emergencies or such incidents happen in the future. At least you have kind of supplies in your warehouses to respond. Also, thank you.
I'm sorry. Thank you for your remarks there, and I think it's such an important point that you made, and also Adam, you spoke to it a bit earlier about how constrained the healthcare system is, and I think it's no surprise because Turkey does host the largest number of refugees in the world, nearly 3.6 million people, and Adam, you spoke earlier about how important it is to make sure that we're reaching the most marginalized groups, and often that includes refugee populations who, as you said, Michelle, may have been displaced a few times already, and it's just not possible for the existing systems to reach every person in the most effective way. So Adam, could you speak a little bit to how you can effectively work in a resource constraint setting and make sure that you're appropriately responding to meet the needs of the most vulnerable populations?
Sure. I mean, I think speaking for Project Hope, this is going back to how we transitioned our response, and at the outset that was very much focused on working almost wholly with the government institutions in Turkey of the Ministry of Health and the various health directorates in the provinces. But that was partly because we're new in country, and this was assessed as being the quickest way that we could fill gaps and support those in need. Over time, we have to think more about our humanitarian principles of independence and impartiality, and we've developed better monitoring mechanisms. We've developed the partnerships that I've talked to you about before. And these are all geared to make sure that the criteria for people receiving any services or relief items is very clear, is equitable, but also considers inclusivity, persons with disabilities, women and girls, female-headed households, etc. So, for Project Hope, we needed a few weeks to get to that stage, but going forwards, this is how we will continue. And again, this applies to the both. There is a clear distinction between the Syrian population and the Turkish population. It's such huge volumes that this cannot be ignored. Now, Turkey has a very robust and healthcare system. It's advanced, it's developed, but as a Syrian refugee, or then you have more barriers to that healthcare system. You have more barriers to the education system, to the employment, therefore money, legal assistance. When you comprise all these things, that is the exacerbation of the vulnerability, and that's where we kind of have to make sure that we orientate, not all, because there are very vulnerable affected populations that are Turkish. It is both, but we have endeavored to make sure that our approach is equitable across the board.
Such an important point, and I think before we turn to the audience for questions, which you can pop into the chat now if you'd like to, and we'll come back to them. I think the power of this community that we have with PQMD and the people on the call today is that our organizations have the ability to make an impact. And so before we kind of jump to the Q&A section, I wanted each of you to kind of talk a little bit about the importance of continuing to support this community. And we all know that the region has been woefully underfunded. So are there any talking points that you can give the attendees listening today to carry forward to try and ensure that it doesn't take another earthquake for more resources to be provided to this vulnerable population? So if you had a minute or two maximum to share those reflections, what would they be? And then we'll turn it over to Q&A. Sorry, yes, go ahead, Adam. We'll go the other way around this time. Adam, Mohammed, finish with you. Michelle.
Sorry, I wasn't sure of the order. I mean, you said it before, and I think it's an obvious answer is funding. It is woefully underfunded given the context. And as I said, yes, the Turkish government, speaking for Turkey now, I will leave Syria to Dr. Al-Jassim. But speaking for Turkey, yes, they have a huge amount of resources. But as I said, there is that vulnerable population and beyond that the humanitarian community is there to support, and that need is going to remain. This is going to be a multi-year crisis. It was pre-existing. It's now deepened, and so there needs to be an injection of funds that allows organizations such as IRC, Project Hope, to start planning longer-term activities that lead us into the recovery phase. At the moment, there is little of this from the typical institutional donors that we might have expected funds from. I would say, and I'm not going to call anyone out, but I would say that it's quite common knowledge that there are significantly lower amounts of money coming to Turkey and Syria than compared with Ukraine and and possibly Sudan and other crises. And so, you know, it's very important that the money comes, but it's a very geopolitical conversation, and I'm not going to get any closer to it than saying that. And I think that regarding access to, you know, Syria, we have the Security Council resolutions on the near horizon, and you know, we just hope that the access, as it sounds now, is continued, so we can, you know, reach these you know, populations that are somewhat cut off otherwise.
Thank you, Adam. Over to you, Mohammed, for a minute or two on final reflections and kind of asks of the community to take forward before we turn it over to Q&A. Well, Michelle, and then over to Q&A.
Yes, actually, particularly for the northwest of Syria, as all of us knows that the 10th of July, there's been a decision for the Security Council resolution to vote against the renewal of the resolution 2642. So, which is the last hope for the population in Northwest to get more supplies, regardless of these supplies, it's medical or non-food items, food items supplies. So this is an urgent call to the international community to have this resolution renewed again, and also it's not renewed for a short period. So unfortunately, in the last 2 years, the renewal was for a short period, for 6 months, which will not allow anyone to have a proper planning and comprehensive planning for the next years. So this is the first issue which might be have the light here in this session. And the second issue is related to the capacity building or the investment in both the human resources and the infrastructure. Unfortunately, due to lack of the health workers, I am speaking for that sector in specific. So unfortunately, during the past years, those health workers who have been, let's say, sieged in this controlled area, they have not trained enough. They have not. They don't have access to the up-to-date information. So investment of the local human resources and to qualify more health workers who can be dedicated to the health facilities, and so at the same time investment of the infrastructure. So the health facilities in Northwest used to be before the crisis schools or the culture centers or even part of the housing system, which is not any preferable to meet the basic standards, basic global standards. So it's also one of the priorities to invest more in the infrastructure, just to make sure we have health facilities that can meet with the infection and prevention control, can meet with the hygiene standards, can meet with the basic global standards to afford the quality health services. Thank you.
Yeah, I agree. Coordination and information sharing is absolutely huge. I think the need for communication really only increases when you have scarce resources. And I think it's really important for us to keep talking about this. I really appreciate PQMD putting the panel on to talk about kind of a shared goal across the membership here. And I think something else that PQMD members can be doing is, or striving to do anyway, because these are all challenging things to do, is to ensure that donors and local actors and politicians and literally everyone in between are kind of clear on what it takes to support a context like this. The average layperson doesn't know that recovery from a hurricane or an earthquake can take 10 years, let alone, without a war underlying it. So, unfortunately, media coverage moves on. Politicians have a much shorter planning cycle. That's just sort of the reality of how things operate. So it's just really important for us to be making sure that everyone is aware of these things and the actual time it takes to do this work, and the resources that are also required. And I think that's another point, is that we should all be striving to make long-term resource commitments to local partners where possible, and include long-term planning in that process that incorporates the local partners and local organizations in that planning to consider resilience goals, no matter how small those might be. And then I think because we know that emergencies will continue to happen on top of this larger protracted emergency, we need to keep or try to keep some of our resources flexible when we can, so that way when there are cholera outbreaks or another earthquake takes place, we are able to quickly pivot and support things we might not have been able to support otherwise.
Thanks, Michelle. It segues actually into a question that just came through on chat from Heather Watts from Health Partners International of Canada. She asks, how do your organizations balance these shrinking resources? As you said, many organizations and even governments might not have these long-term planning windows to be able to commit funding. And unfortunately, news sometimes moves on and people don't continue to donate. So when you have these shrinking resources, but continue to have high needs and high security risks, how do you balance that? Is there anyone that would like to speak to that first? Mohammed, yeah, I see your hand up. Please go ahead.
Yeah, actually, we are working in a war zone. So there's kind of high risk for all the aid workers who are working in any war zone in the world, regardless Syria or another country. So there's kind of high risk that everyone is paying attention to this kind of high risk and making a kind of mitigation methods how to reduce the risks might be imposed over the health workers. So in particular for the health, actually, most of the health facilities recently started to be located in far away areas of the front lines, just to make sure that these health facilities will not be attacked by explosions or air attacks, which is the first, let's say, the first mitigation measures. The second issue, action, which also implemented by everyone, is related to make more comprehensive health facilities that can provide different level of cares in one health facility, just to make sure that there's cost efficiency and there's a full package of health services can be provided in one health facility, like surgical hospital or the health facilities that can provide primary health care, secondary health care, even sexual reproductive health care, even emergency services that can provide in one unit, just to avoid having many health facilities in different location areas that can make a burden on the patients to access it. Also, to make burden over the international organizations or even the local partners. They have to dedicate a huge fund for this. And the third line that all the health actors are working right now in light of this shrinking of fund is the centralization of the health system, or having one unit who can plan to this health system in the future. So we can have this compromised health system that's controlled, let's say, by Ministry of Health or Health Directorate or even under the health cluster umbrella, just to make sure that there's one decision can guide all the health actors in Northeast.
Thank you. I did get one other question in chat that I think is related to the coordination that you spoke to around metrics. And I think there are some people on this call that are interested in learning about what metrics you're using to understand your impact in this crisis. Is there anyone that would like to speak to metrics or that would be comfortable sharing that? Adam, yeah, please go ahead. Thank you.
Sure. Okay, so we work off basic common assumptions that, if you do X, Y will happen. And I think in an emergency of this scale, that is fair in the initial phase. And, for Project Hope, as is the case with other humanitarian actors, in the first weeks and maybe months, you're looking at short-term impact rather than longer-term outcomes and a longer-term theory of change. So you're really we're looking at measuring what happens if we give X here to Y, etc. So it's fairly basic, but that's what's necessary. We have monitoring, evaluation, and learning frameworks that help us capture the information that our activities are generating or our partners are generating. But importantly, at the very outset and throughout implementation, we have community-based feedback and response mechanisms, which means that individuals that are the recipients of activities or supplies are able to provide feedback to us, so we know, is it still relevant? And this is important. Perhaps it's not a metric, but but it's an important aspect of our accountability to affected population commitments. I guess going forwards, the next stage would be, patient satisfaction surveys with in our healthcare facilities, and that is what we will be doing once we are up and running with the 2 facilities I mentioned in northwest Syria. So yes, I mean, I think I've discussed the data management at length, and I think that you can wait too long to get the correct data to inform decisions. And an earthquake yields very similar outcomes in every context. So there are certain rules of thumb that you can follow that, and best practices that you can follow in line with sphere international humanitarian standards, et cetera, et cetera. That means that, your metrics are going to, be relevant, shall we say.
Thank you, Adam. And Michelle, I think we can turn it over to you to add to the question on metrics if you're able to, and if not, we can close up and hand over to EJ. But if you'd like to just share some final remarks to close us off, that would be wonderful.
Yeah, I think a lot was already well covered, but I would just add that, we're doing a lot of triaging of immediate needs because of the fact that this is a war zone in northwest Syria, and that's still something we're going to have to continue to deal with, especially because it's under-resourced. But I do think that the more we can build in these measurements for patient outcomes, we've been getting to occasionally test, cash for health tied to physical health outcomes, and also, does mental health and psychosocial support actually affect those reported outcomes and those types of things. So there are some small silver lining moments. I think everyone is really trying to look for and work towards on these sort of challenging measurements.
Thank you, Michelle, and thank you to all of you, to all of our panelists for joining and sharing such important reflections and remarks about the great work that your organizations are doing on the ground and through partners. Thank you to everyone who joined. I'm going to turn it over to EJ now. Elizabeth Ashbourne is PQMD's Executive Director to provide some closing remarks, and then it'll be a goodbye from us. Over to you, EJ.
Thank you so much. Just a really quick thank you for everybody who joined us today. And also a very special thank you to Courtney, Dr. Muhammad, Michelle, and Adam for your insights and perspectives. One thing I would like to mention is that, first of all, the questions were really, really interesting, and your remarks were really profound. We are in the process of developing our agenda for our education forum in this coming October. And many of the issues that you brought up are actually ones that we will be addressing collectively as an organization in October, specifically around sustainability, resilience, and continuing and dwindling resources and exit strategies, and decisions to go in and strategic decisions to go in the first place, but also, of course, the conversation around metrics, which is absolutely key. And I thought it was particularly interesting that you talked about you can wait too long to get the data, but of course you can't get the data unless the people that you're working with can actually give it to you. So particularly in a crisis, that's a challenge that we all deal with. So I'm really excited to continue that conversation, but more to come, and keep an eye out for that agenda that's coming for October. But at PQMD, we do continue to strive to shine a light on crisis around the globe to promote sustainable access to quality healthcare. And thank you. And please be sure to join us as we continue to bring you webinars and host intriguing online discussions through the PQMD's community of practice. Again, if you haven't signed up already, please be sure to. And this webinar will be posted there within a few days for you to review or to share with your colleagues. So thank you so very much, and enjoy the rest of your day.
Thank you. Goodbye.
Thanks, everyone. That was great. Thanks so much. Great comments, great conversation. Really enjoyed it.